Hello guys, I am Dr. Deepak Garg. I am an orthopedic surgeon and today we will discuss about clinical practical guidelines for management of acute spinal cord injury. So when a patient will present to us in the emergency department, it will be most probably a traumatic event and patient will have a sensory, motor or autonomic function involvement. And when the patient is having a trauma or a roadside accident, usually the injury to the spinal cord, we see it in two phases. So the first phase is a primary injury and the second phase is a secondary injury. We can call it as a first hit and a second hit. So the first hit or the primary injury is because of the fracture. It can be a vertebral body fracture or like a burst fracture, or it can be a dislocation like a facet joint dislocation. It can be hyperextension or the flexion injury, or it can be because of the compression to the disc because of some bony fragments. So the primary injury is usually at the time of trauma. So when the trauma is happening, that time the injury to the spinal cord is a primary hit. And the secondary hit or the secondary injury is because of the biochemical cascade. So this is a biochemical cascade that lead to the cell death. So let's discuss in detail about the biochemical cascade that will ultimately lead to the cell death. Because the primary hit, we cannot do anything about the primary hit. The primary hit is a mechanical damage to the spinal cord. So when the patient will present to us, it has already happened. So we cannot do anything about the primary hit. But the secondary hit is a biochemical cascade that will happen from 24 hours to 1 month. So we may protect the patient from the secondary injury. So we must understand these concepts of primary and the secondary injury. So the primary injury is because of the mechanical damage, because of the fracture, because of the microhemorrhage. So let's see the structures inside the spinal cord. So the spinal cord have neurons, so that can be injury to the neurons. It has axons, that can be injury to the axons, blood vessels or the cell membrane. So all these structures can be damaged during the injury, and that is the primary injury. Now when the patient will present to us, it has already has the primary hit. Now the biochemical cascade start and the patient start having the secondary injury. So these are all the steps in which the secondary cascade is happening. Let's understand in detail about the normal physiology of the neuron, so that we will be able to understand the secondary cascade of the secondary injury. So let's say this is a neuron, this is a synapse, and this is a extracellular, this is a intracellular. So sodium, potassium, calcium is higher on the outer side of the membrane and it is lower on the outer side of the membrane. So the outer side of the membrane is always negative. This negative is usually minus 70 millivolt, and this is a negative potential, that is polarized cell. When this sodium and potassium will come inside via sodium potassium channels, they will lead to the depolarization. This negative will become positive. And when this depolarization will happen, there are calcium gated channels here near the synapse. Say this is synapse. So this calcium will enter inside the cell and it will lead to the neurotransmitter release via NMDA receptors. So this will lead to the neurotransmitter release. This is glutamate release. So this way the neurotransmitters are released and the signal is passed from the cell. So considering this, keeping this in mind, let's look what happens in a spinal cord after the primary injury. So we have seen the primary injury. Once the primary injury will happen, there is a mechanical trauma. So we have already seen there can be fracture, dislocation or compression. So this will increase the pressure within the canal. So when the pressure within the canal is increased, there is a vasogenic edema. When the vasogenic edema is happening, there is a microvascular damage. When the microvascular damage is there, there is a microvascular vasospasm and thrombosis. This will lead to the decreased blood flow, decreased oxygen and poor perfusion in the spinal cord, and it will lead to the spinal ischemia. When there is a ischemia, there is a loss of ATP. And in the normal scenario, that calcium or sodium potassium channel or the pump is maintained by the ATP. When there is a loss of the ATP, this sodium potassium channel will open and there is a sodium potassium entry into the cell. When the sodium will enter the cell, there is a ionic imbalance and there is a depolarization starts. So when there is a depolarization, so the calcium there is a voltage gated calcium channels, they will open. When the voltage gated calcium channels will open, along with that there is a disruption of the cell membrane. So there is a continuous influx of the calcium from outside to the inside. So this will lead to the excess neurotransmitter release, that is glutamate excitotoxicity, because the calcium is continuously coming into the inside the cell membrane. So there is a continuously release of the glutamate, that is glutamate excitotoxicity, and there is a continuous opening of the NMDA receptors, because there is a continuous influx of the calcium and NMDA receptors are not closing, they are consistently open. So they lead to excessive release of glutamate, and this massive calcium influx, this lead to the calcium overload inside the cell, intracellular calcium overload. And when there is an intracellular calcium overload, the calcium is maintained by the mitochondria. It will enter the mitochondria. It will lead to the activation of the destructive enzymes like protease, endonuclease, phospholipases, and there is a mitochondrial dysfunction. And when there is a mitochondrial failure, it will lead to the formation of reactive oxygen species and ultimately the lipid peroxidation. And the lipid is a main component of the cell membrane, and the cell membrane will get damaged. When there is a damage in the cell membrane, the DNA are fragmented and it lead to the cell apoptosis. So there is a cell death. So when this is happening, there is an injury to the oligodendrocytes also, and this will lead to the demyelination. And this inflammation cascade continues and lead to the microglial activation and the macrophage infiltration. Now when all this event has happened, say this is the necrotic area, see this is a necrotic cells. So what will happen, there will be astrocytes, macrophages, they will come, they will form a barrier around this necrosis. They will form like a wall outside this necrotic component. This is called glial scar. So this is happening because the body wants that we should stop this inflammation and the more damage should not happen, and this is called glial scar. So if there is a formation of the glial scar, this indicate that there is a body is trying to prevent the further damage, and there is a physical barrier to this inflammation, and this is a process where we can say that the further damage will not happen. So this is a secondary injury cascade that we must remember. Now let's solve multiple questions. So when a patient is presenting to us in the emergency, should we intervene early or late? Should we intervene in less than 24 hours or more than 24 hours? So if we intervene early, we will be able to prevent the secondary injury. So we will be able to prevent the cell apoptosis, cell death, and this excitotoxicity. So all these cascade we will be able to prevent. So early intervention is considered better if we can do it. Then why there is a role of steroid? Why the steroids were tried? Because if we give steroids, they has the potential of stopping this inflammation and we can prevent the secondary injury. So the steroids were tried. But the complication of steroids should also be considered, like infection. Then why hypotension worsens the outcome? Because if there is a hypotension, there is a decreased blood flow, and this decreased blood flow will further increases the ischemia and the secondary damage. So hypotension is not acceptable. Even if we will have to give the drug, we will have to maintain the normal blood pressure or slightly towards the higher side to prevent the secondary damage. So all these steps were done to prevent the secondary damage. Now, what are the areas of controversy? Use of methylprednisolone, number 1. We will look at these in detail. Number 2, timing of surgery. Number 3, timing of anticoagulation. Should we give anticoagulation to spinal injury patients or not? And number 4 is role of MRI. Let's look at all these questions one by one. Number 1 is timing of surgery. Early is less than 24 hours. Late surgery is more than 24 hours. So if there is a persistent compression, that will maintain the ischemia, that will worsen the edema, and secondary cascade will continue and more damage will happen. And if we remove the compression, that will increases the perfusion and reduces apoptosis, and ultimately neurological recovery will be faster, damage will be low. So early intervention is recommended. Number 2 is role of methylprednisolone sodium succinate in acute spinal cord injury. So MPSS was considered because it is anti-inflammatory. It will reduce lipid peroxidation and cell membrane damage, prevents neurotransmitter neurofilaments, improves cord blood flow, and enhances sodium potassium ATPase. So these are, we have already seen that MPSS, it will reduce the inflammation and the secondary damage. According to the 2002 AANS and CNS, these guidelines, MPSS was optional, but 2013 guidelines recommended against MPSS. But NASCIS2 trial, it shows that there is a small neurological improvement when given within 8 hours for 24 hours, only for 24 hours. Then there is a benefit in the patients. So there is a subgroup, but this was criticized because of the subgroup analysis, marginal benefit, and they had significant complications. Now it is very difficult. There is giving a steroid is an optional, and it is not approved by FDA. There is no class 1 or 2 benefit, clear evidence of harm because of infection and other problems related to steroids. Now the guidelines is MPSS is optional, time sensitive, and risky, not a standard of care. Now MPSS, when should we give it? Like if we are giving it in less than, patient is presentation is less than 8 hours and we are giving it for not more than 24 hours, then what dose should we give? Loading dose of 30 mg per kg IV over 15 minutes methylprednisolone, and we take a gap of 45 minutes, and then we give a infusion maintenance dose of 5 and 4 mg per kg per hour for 23 hours, like total of 24 hours regimen, and then we stop after 24 hours. And do not start, if the patient is presenting after more than 8 hours of injury, then we should not start the steroids there. So this is about the steroids. Then about the anticoagulation prophylaxis, why should we give anticoagulation? Because of, if the patient is not able to move, there is a paraplegia, patient is immobile, so there is a very high risk of thromboembolism or thrombotic events, because a patient is having a neurologic dysfunction, endothelial injury because of the inflammation, and patient is a hypercoagulable stage because of the inflammation. So we can start the anticoagulation prophylaxis. Now the risks of anticoagulation are, there can be a formation of spinal hematoma, there can be increased cord compression and neurological deterioration, there can be bleeding. So the prior guidelines were saying that we can give low molecular weight heparin with IPC, and AANS and CNS were suggesting early prophylaxis, and they were about avoid oral agents. Now what should we do? When the patient is stable, spinal cord injury, there is no bleeding, we can start early, like low molecular weight heparin, 40 mg enoxaparin subcutaneous OD within 24 to 72 hours. Then if it is a post-spinal injury, post-spinal surgery, we can start it after the hemostasis is confirmed. And in case of polytrauma, we should take a multidisciplinary decision. We should coordinate with the other surgical team also. And If there is a high bleeding risk, we should give only mechanical prophylaxis. We may withhold the IV or the subcutaneous prophylaxis. Now if we are giving it, what duration should we give? If the patient is a complete spinal cord injury and there is a paraplegia, then we should give it for at least of 8 to 12 weeks. And if there is an incomplete spinal cord injury with early mobilization, we can give it for 6 to 8 weeks. And if patient is early ambulatory, we can give it until the patient is mobile. And if there is a ongoing immobility, we can give it for more than 12 weeks also. So it depends on the patient mobile status. If the patient is immobile, we should continue it. If it is mobile, we should stop it. So time is not a criteria for keep continuing the prophylaxis. Mobility is the criteria. Now, what is the role of MRI? So we have already discussed that CT is the standard investigation of choice, and for management decision taking, CT, we can definitely take decisions on the basis of CT. And MRI is done only if the CT is normal. After 28 to 48 hours, so we can do MRI to look for the spinal cord injury or the ligamentous injury. The guidelines are also the same. Prior recommendations were MRI is optional. In 2030, there were level 3 recommendation, and the MRI is valuable but must delay for life-saving surgery. So for surgery, MRI is not compulsory. We can do surgery on the basis of CT. So this was about the today's topic. Thank you guys. Thank you for watching this video. For more such video, please like, share and subscribe to our channel.